And welcome to another wonderful episode here at Doctors of Podiatry. A very interesting case. We have a young gentleman who's extremely active in his in respect to his occupation. Patient presented with a chronic pain to the back of the heel, the right heel specifically. The pain from the clinical presentation has been affecting his daily life activities. We did speak quite a bit with the patient in respect to conservative treatments. I think the patient at this point has, it's been a very, very long time. We'll say 4 years up and down. And he finally, I think, has made the decision that he wants to sort of try to get rid of this problem. And that's exactly what brought him here to Doctors of Podiatry. So, we recommended that we do a percutaneous microtenotomy, also known as, like everyone knows, a dry needling. We're going to go ahead and use, we've already, number one, we've already demarcated the area. The area is also already numb, okay? And we're not only doing the dry needling, which is the acupuncture technique that we use, then we're going to go ahead and inject some PRP, and then we're going to also cast the patient for some custom molded inserts because of his level of activity. And we'll throw some heel lifts in there, and eventually we'll get the patient to physical therapy. During the course of the next 2 to 3 weeks, he's going to be immobilized. He's going to be using a cam walker. He will be able to work if he wishes, but without further ado, let's move forward. I just want to remind everyone again, Achilles, whether it's heel pain or plantar fasciitis, Achilles tendonitis, anything that ends with itis, we continue to use this cocktail, so to speak, to maximize improvement and minimize any long-term complications. So let's Patty, come on, let's show everyone like we always do. So again, what we're doing is we're essentially, and I can feel, right, the celery, like, you okay there, bud?
Yeah.
Okay. In a very controlled fashion motion, we're just fenestrating the Achilles. A big no-no that a lot of people don't know, and some doctors also do it still, is injecting the Achilles with cortisone. It's very risky for a lot of reasons, but primarily the cortisone can actually degenerate the tropocollagen and the collagen. These are the important what makes up the tendon, and that can degenerate the tendon, and believe it or not, a little bit of cortisone can actually make the tendon partially snap. It's not really great. I've never been, there are people, doctors that do it, my hat's off to them. There is a bursa in front and in back of the Achilles tendon. Okay, so the Achilles is here. There's a little bursa here. There's another little bursa here, the retrocalcaneo bursa, that usually gets inflamed, and that's probably also what he has a little bit of. So now what we're going to go ahead and do is, I'm going to go ahead. So we always, we pre-bend our needle a little bit, and now what we're going to go ahead and do, my friend, you may feel a little bit of pressure, maybe a little discomfort. Okay, if you do feel any discomfort, please let me know, and we'll slow down in the infiltration. Okay.
Yeah.
The reason why I've said it and I'll say it again for all the viewers out there, it's not discomfort because of the PRP. It's actually volume expansion. You're filling in, right, layers, and this is a really tight space, so it will create discomfort. We do have cutaneous nerves all around this area, and it hurts, it bothers. Patty, why don't you come from behind? There you go. I think you'll get a better. Okay, so you know, we'll start here. Right, and we go straight into the Achilles, and then we slowly. You okay there?
Yeah.
Pain?
No.
Good. Very slowly, because we want to make sure we keep all the PRP in this area. We don't want it to move to any other locations, right? So I'm about right here, if anyone is wondering. Okay, here we go again. Always we infiltrate on the way back. Coming through here. You okay there, bud?
Yeah.
I'm not pushing a lot of it in this area. I know that this is the area. I'm gonna leave that for last. Patient's doing absolutely wonderful. This is the area here, so I'm gonna come from right here. Okay. Right around here. Right here. I'm gonna drop the rest here. And just like that, we're done. Just a quick recap. We went ahead and did the percutaneous microtenotomy. That was the first part. The second part, we went ahead and did the PRP, the platelet-rich plasma injection. The patient was already casted for the custom orthotics. Those will take about 3 to 4 weeks to fabricate. He'll be able to move those from shoe to shoe. And we're gonna go ahead and immobilize the area with a cam walker, not a low profile, a high profile one. And just to take it easy during the course of the next couple of weeks. What the patient has done today is an investment, okay? This is investing in his health. This could be detrimental because it's very simple. With the amount of inflammation and with the amount of time that has gone by, there's a very high likelihood that the tendon can continue to degenerate to the point where it can actually start to tear, little micro tears, what we call intrasubstance tears, and those are not good. So like always, I want to thank everyone for watching. www.josspodiatry.com, Instagram Dr. Toe Jam, our Facebook fan page. You like that, right? We have a guest here just watching here today. Our Facebook fan page, Joss Podiatry, and last but not least, our YouTube channel, Joss Healthcare. Thank you for watching.